and CEO. It is my pleasure to welcome everyone and the wonderful panel of philanthropic leaders that you will be hearing from shortly. NAC, like health centers, our primary care associations and networks, have all depended upon the generosity of the private foundations, generous donors like our panelists today, and other nonprofit partners. This sector has really stepped up over the years to drive change. They have delivered new programs and initiatives that have become important part of the health centers. Programs like the Prepare screening tool, the leadership development programs like Match, innovative staff training programs, capital development campaigns nationwide, programs for natural disasters, and most recently, including new funders and donors during this COVID-19 crisis. Before turning over to the team, I wanted to recognize the hard work of our health centers nationwide, the stuff they are doing and the accomplishments they are doing every day. Last week alone, we saw the White House recognize over 10 million people have been vaccinated by health centers, and over 15 million tests have been administered. Over 60% of those were minorities that were served by health centers and receiving the COVID services. Since the beginning of this pandemic and the beginning of this movement, health centers have led from a point of equitable access to healthcare. As you are seeing, we no longer are the best kept secret in healthcare. We are the model. Finally, I want to acknowledge today, May 25th, as the one-year mark since George Floyd was killed. His death, along with the ongoing acts of hate and violence against so many others, remind us of how far we, as a nation, still need to go. Health centers have long known what CDC recently declared, that racism is a public health threat. But high quality, accessible, affordable, equitable health care alone can't cure racism and hate. But what health centers do every day on the front lines of America's underserved communities does help address and heal the health disparities and racism. Their commitment to this common mission helps to heal us all. So a real big thank you to all of you today who comprise today's health center community, health center movement, and to our partners, our funding partners, for all that you do each and every day. Thank you again to our panel, and I look forward to hearing this discussion. It is my pleasure to introduce to you our Senior Vice President of Development and Innovation, Meryl Warshoff-Press. Meryl, take it away.
Thank you, Tom, and thank you to everyone who has joined us today. Before we begin today's panel, I'd like to give special thanks to the RCHN Community Health Foundation and Dr. Feygele Jacobs. Earlier this month, the foundation announced a very generous grant to NAC that will fund the launch of our new Center for Community Health Innovation. Celebrating NAC's 50th anniversary this year reminds us all that health centers have really been innovators since the very first neighborhood health centers were founded in the 1960s. The Center for Community Health Innovation will work to assist and support health centers in their efforts to increase access to affordable, equitable, and quality health care. We will identify, develop, and disseminate innovative, value-driven models necessary for success for the next 50+ years. This center will reside in our Development and Innovation Division and the Office of the President, where we will continue to build and lead the strategy to generate new resources and develop key partnerships, such as our partnership with Direct Relief, which you'll hear more about shortly. And let me just say that we are truly appreciative to all of our partners and funders. Your tremendous support is invaluable, not only these last 15 months of the pandemic, but year in and year out, and we look forward to working together for many years to come. Jason Patnash is our Associate Vice President, and I'd like to turn this over to him now to introduce our panel. Thank you.
Thank you, Meryl. I am thrilled today to introduce this panel of leaders, colleagues, and most of all, friends. Let me start with our moderator, Dr. Feygele Jacobs, who leads the RCHN Community Health Foundation, America's only foundation devoted exclusively to community health centers. The foundation is not a stranger to many of us. Their signature programs have focused on expanding access and helping health centers enhance their capacity, along with strengthening their operations. Carmela Castellano-Garcia is the president and CEO of the California Primary Care Association, representing more than 1,300 nonprofit community clinics and health centers, serving 7.4 million patients annually in the state. Ms. Castellano-Garcia has been committed to advancing multicultural health policy issues for nearly 30 years. She is also president of the Board of Trustees for the Castellano Family Foundation, a family foundation supporting the arts, education, and leadership development in Santa Clara County, California. Misty Lewis currently operates in a dual capacity, serving as the External Affairs Director for HealthNet Inc. and FQHC, and Director of the HealthNet Foundation, 501c3 public charity located in Indiana. The HealthNet Foundation was established in 2018 to help raise funding to support programs and services of HealthNet Inc. Also, over the past several months, Ms. Lewis has brought together NAC with other health center-based foundations on monthly calls to expand networking and learn from each other. Earl Millett is a senior program director for the Harry and Jeanette Weinberg Foundation, supporting several areas in health, including access, aging in community, nutrition, and trauma. Capital support to enable older adults to live in communities like PACE centers are funded through the foundation nationally, while other health initiatives are funded through a handful of priority communities across the U.S. Prior to the foundation, Mr. Millett served as the COO of Civic Works, a nonprofit transforming the lives of Baltimoreans through community service and skills development, and is a returned Peace Corps volunteer, having served in Ecuador. Finally, Thomas Tighe has served as president and CEO of Direct Relief, a nonprofit humanitarian medical organization, for over 20 years. Since Mr. Tighe's arrival, the organization has provided cash grants of more than $120 million and furnished more than $8 billion in essential medicines, equipment, and supplies to support health centers in over 100 countries and all 50 United States, where it conducts the largest nonprofit charitable medicines program. Every single national disaster since Hurricane Katrina has seen Direct Relief serve as one of the first to step up to check in on community health centers. Through their responses during COVID pandemic, Direct Relief has sent PPE, supplies, and millions in unrestricted financial resources to community health centers. I'm honored to turn this panel over today to our moderator, Dr. Jacobs.
Thank you so much, Jason, for your kind introduction. I'm very excited to be here with you today and with our great panel. We'd like to start by looking at where we are at this unprecedented moment in history. Over the course of the past 15 months, community health centers have gone through the most extraordinary strain in their more than 50 years of existence. It's been an extraordinary strain on the healthcare system overall, and yet health centers are emerging stronger. And what we've seen, as Tom Van Coveren said, is that community health centers are no longer the best kept secret in healthcare. Health centers have been designated as leaders in ensuring equitable access to care, to COVID-19 testing, to the vaccines. They're actively engaged in advancing discussions on the social determinants of health. And of course, they're an essential part of the frontline workforce that has gained a newfound respect in society. So with this backdrop, what I'd like to talk about with Earl and Thomas initially is, why is now the moment when philanthropy should be furthering its investment in community health centers? And I'll just say that for us at the RCHN Community Health Foundation, we had a long-term vision And we have been very deliberate and strategic in looking ahead, in planning out our investments, but we also had clearly defined some short-term goals. And that I would say that this moment really presented itself as an opportunity for us to accelerate our giving, to make some larger investments now that we think are going to be beneficial over the long term, hence the gift that we've just made to NAC. So with that, I'd like to turn it over first to Earl and then to Thomas. Thank you.
Thank you, and thank you so much for this opportunity to talk to such a great group of people that are doing so much important work all throughout our country. It's a great question. Why now? 15 months ago, we didn't know the pandemic was coming. We certainly didn't know the specifics of how this pandemic would impact folks, but it was health centers that were prepared already through decades of preparation, through doing buildings, through getting the staff together to being prepared. Partly because what they did know was that this country has a lot of inequities that hit people disproportionately, especially around health and social determinants of health, as you mentioned, and they were preparing to fight that. And the pandemic has laid bare what many of us already knew about those inequities, but brought forth the data that really shows how important it is to combat it. And I have been overwhelmingly impressed by the data that is coming out of the health centers throughout this country, specifically the health centers that the Weinberg Foundation has been lucky enough to support. Just seeing those early vaccine doses that have been coming in this year, going to the highest need populations, going into the urban areas, going to minorities. And it was not something that was a change for health centers that changed in this past 15 months. It's really something that was a part of the spirit and why they were together and all the work. So investing now is just preparing, hopefully never for something quite like this, but for the health inequities that we've been dealing with for decades, and to really work to change that so that hopefully not, if we should ever deal with something like this again, we won't have the horrendous data we did from the beginning year of the inequity of impact that COVID had. I think also we've learned the need for telehealth and the expansion for that. So capital needs coming from the government, but support from philanthropy will be needed to help add the unique aspects that we've learned of more remote login. And then the last thing I will say is, and just to piggyback on what you said, the workers at the health centers are really such heroes in everything we do. And if we support them with words and calling them heroes, that's not enough, but supporting them with the resources to make their work setting safer, healthier, whatever they need. From our standpoint, it's capital investment to provide the services and go in. As you can see, I'm working from home still. I am the definition of non-essential employees, but we definitely want to be there for the essential employees.
I agree. Thank you, Earl. You're a much better dressed former Peace Corps volunteer than I am today, so thanks for that too. But no, I think it's a great question, Dr. Jacobs. I think for me, it's always a good time to support health centers. I think they represent a very large, important proposition in an important way every day. And I think when we saw COVID coming on, our experience at Direct Relief was aim at the health centers because disasters are largely unpredictable. Some are predictable within a range, like hurricanes happen in certain places at a certain time of the year. But what's always true, and it doesn't matter what type of disaster it is that people who are hit hardest and have the hardest time bouncing back are the people in the least fortunate situation to begin with. And that kind of defines the patients of community health centers, and that the health centers exist, that they have not only new data, but they have data for decades. I think everything that people say they want, access, affordability, equity, quality, and it's generally, pick two or three, but not all. The health centers have been doing all of those things for years, with remarkable dedication and great facts, both health facts and outcome facts and data, but in communities that are underserved. And as we had this reawakening in society with the death of George Floyd, and it was almost like getting back to when the health centers were founded and why. I mean, it wasn't a surprise to a lot of people. I think probably most of the health center folks, when they saw COVID arriving, thought, okay, this is going to hit our folks hard, because emergencies always hit health centers hard. But for direct relief, it's always the best place to plug in. We exist, and a lot of our ongoing work is to support the chronic needs that exist. I mean, it's largely federally funded, and that's great. And NAC does an amazing, important, essential role of making sure folks don't forget those 30 million people who rely on health centers as the front door to their health access. But federal funding, and I say this as a former federal official, it's highly, circumscribed. It doesn't give the flexibility. So when we have the opportunity to provide funding, in addition to the stuff that we kind of specialize in, we like to make it discretionary. We think, look, you live there. I mean, Puerto Rico being a perfect example. We've been working there for 10 years prior to Hurricane Maria, supporting health centers for some chronic needs. And when that storm came and just slammed the island, that was the first place we plugged in, because we knew the people who were going to be in the toughest circumstances after were the same people who were in the toughest circumstances before. That's always true. And the health centers are always there. So for us, it's, always important. But I think the what it represents for, the world, and certainly American society, is who's been doing what we all say we need to recognize and acknowledge and embrace and do something about now. Well, the people have been doing it for 50 years. That was the raison d'etre for their creation in the aftermath of the civil rights movement, is a key part of it. I mean, outlawing discrimination is one thing, but making that didn't redress what had accumulated over the years. And health centers stepped in, and they've modeled behavior that is both deeply dedicated, empathetic and personal, efficient and tough. They don't get intimidated by tough stuff. So I think it's the best bet that any philanthropist could make. If you want good data, go to the health centers. It's standardized across all 50 states. You're about access, go to the health centers because they provide it. You're about health equity, go there, because 63% of the patients are members of racial and ethnic minorities. Thank you, Jason, in the NAC chart book that I was just flipping through wildly before that, which is also a fantastic thing. So I think for both the reasons of the head and reasons of the heart, reasons of the wallet, and reasons of society, to me, it's fun being a cheerleader and a supporter of health centers. I know sometimes it's hard for, if you're doing it, it sounds like you're bragging. So, I think health centers tend to lead with data, but, I look at them, I just see the passion, the heart, the history that exude. So I think that X factor is always the people. We all say we want data, and we all know in life that leadership counts. So to all of you leading health centers and promoting what you're doing, keeping it together for the people who've gotten slammed the hardest over the past year and a half, thank you. And all the folks at NAC who've been, doing an amazing job rallying support from the public officials. But, we can't just look and say, well, the government needs to do this, all this hard stuff, and punt on it. I mean, it's the best case for public charities in the country, in my mind. I'll say one other thing, because, you're not legally entitled to health care in the United States. You are legally entitled to an education up through high school. Not constitutionally guaranteed, but legally entitled. And there's tons of money raised for public schools. There should be tons of money raised for public charities that are community health centers by and large. It's a great case, and you have I'm just a fanboy out here in California, so count me in for whatever you want doing. And thank you, Jason, for inviting me. And I'm not taking my 3-hour allotment of time, so I'll shut up. Thank you.
Thomas, thank you so much. I'd like to pick up on a theme that you talked about, really a major issue that's unfolded during exactly the same time frame as the pandemic. And the country has really been reckoning with our history, which has been marked by racism, by injustice. We've seen the murders of George Floyd, whose death we're recognizing today on this very solemn anniversary, and of Breonna Taylor, and of other Black Americans at the hands of the police. We have witnessed rising violence against Asian American and Pacific Islander communities. And this has required that philanthropic organizations look at their own giving and examine the role that they've played in addressing institutional as well as structural societal racism and structural issues. So I'd like to start, Thomas, first with you and then Earl, and ask, what responsibility does philanthropy have, not only in responding to these structural and societal issues, but in helping to change the narrative and to creating more equitable giving opportunities and programs as we are thinking about these major issues? Thank you.
Well, that's an easy question. Thanks for that's an easy question, Dr. Jacobs. But, I think that, the philanthropy and the special status that we have in the United States, basically the tax status that is given, it exists to promote the public good. It's sort of like government-like in purpose to promote the public good, but it's private in character. And, it's to advance societal issues. That's why it's given this preferential tax treatment or contributions. Of course, you can't just kind of, as a person in philanthropy, it's weird when you just say what the government ought to do. It's what, if you're in philanthropy, you do. And the benefit of being in philanthropy, I think, is you can move fast. You're bound by broader, serious rules, but they're broader. There's a lot of discretion. So I think it's important to recognize, if you care about redressing these longstanding inequities, the structural racism, things that you can't just declare out of existence by passing the Civil Rights Act and making discrimination unlawful, it doesn't make it good. It just makes the bad stuff illegal anymore. So I think it's really important for those who have the means and the flexibility to see what the money can translate into. Basically money translates ultimately into goods and services, right? And activity. And so that's why we love when we're in the position of giving money. We just know that people who have dedicated their lives to it, it's not just based on the quality of a grant submission, it's based on the quality of the people and what they've demonstrated over 50 years. So for me, the issues, it's a complete punt. If philanthropists of all types don't take another step back and look, it's like, what can we do better? Everyone's for, making things better, but it's hard sometimes to see where to lean in. That's why I think that it's a particular moment for health centers. There's no one who has a track record born out of the civil rights movement, recognizing the disparities that were not corrected when discrimination was made unlawful. That's still true. It's just now normalized. It's kind of accepted that people of color are going to get hit hardest in every single emergency. It's wrong, and I think you have the best standing in a legal sense to say it's wrong, or without making it kind of a controversial issue, lead by example, which I think you do every day. So I think direct relief ended up, because talking to Ruben Moore up in Minnesota, a great health center leader, about a year ago, just saying we're in a moment that is awful, but not a surprise. And we think we have a way to kind of connect with people because there are people. So that led us to creating, without any idea that we would do it, a fund for health equity that got $75 million put into it without even asking anyone. And I think because we said, well, our view is that we're in a moment where you've got to put out the fire. It's like in California, the state burns down every year. So, you got to put out the fire, but you have to think about global warming too. And I think where COVID is the fire, and these longstanding inequities are the global warming equivalent. They don't go away. They take sustained effort, and it needs resources and people in the hands of people who know what to do with it. And I think that's why it's just a privilege for us to launch this, this fund for health equity, most of which is going to go to health centers.
Thanks so much. Well said, and nothing really more to cover on that. I will say that we get a lot of grant applications at the Weinberg Foundation, as all foundations do, that talk about a person-centered approach, and it's something we look for. We want to know that you see the individual client as a person with their own individual needs, and we can't kind of give broad brush strokes to treating things. Well, communities of color for many years, but of course highlighted by what we're on the anniversary of, and more recently with Asian hate and Black Lives Matter, have been screaming at us for a long time to hear what they need. And if we're not funding or supporting what the individual needs are that they're telling us, if we're not taking the time to listen and really listen and digest what is being told to us, then are we really helping? And that's certainly the goal of every philanthropy, private, public. That's the goal of the government dollars coming in, is to help people. And you can't help people on your terms. You need to help them where they are. And they have been so clear. We have, starting to hear that more, need to do more listening. Too often when we talk about racism, there's a discussion of what can be done for the victims of racism. And certainly that's something we want to look at. But whenever you're talking about a crime, and a crime against humanity, racism certainly is, you want to talk about the culprits and what can be done to change them, and not put it all on the victims changing and things that need to be done there. And that is some internal looking at how foundations have given money and looking at where we're giving it to and trusting the communities with those dollars. The trustees at the Weinberg Foundation through the pandemic, because I know this what this is focused on, turned over more operating support to local communities, nonprofits, health centers that were working, that know the area and have been listening for years and understand what the needs are. And they responded with the data that Thomas talked about and the data that we've seen about getting the vaccines out to those who needed them the most. And it just supported that idea of trusting the individuals who are doing the service, but also receiving the service, the community members themselves. Social determinants of health show that we need to, health centers are so much more than just health, and we all know that. I don't need to explain to anybody on this call how health centers reach out towards housing, jobs, education, general case management. And if you're not doing that, you can't solve the health issues of somebody if you're not working on their housing. But I think, like Thomas said, amplifying the message of how much it impacts people. I'll highlight the one thing that the Weinberg Foundation focuses on: older adults. And we're learning more and more, which should have been obvious, but the data is showing us Alzheimer's disease, long thought to be plaques and tangles and different things. But when we look at the data, we see that it affects people of color disproportionately. And why is that? And at younger ages. Is it because of structural racism? Of course, access to healthcare, but also due to the trauma that they've experienced. It's a damage to the brain. And we're learning more and more how all of these health disparities and the damage to the whole family that a disease like Alzheimer's does is a result of racism that needs to be changed. And philanthropy is going to be at those cutting edges, or can be, if they're listening to the clients that we're hoping to help, by starting to make those changes and get that message out there at how important it is.
Thank you, Thomas and Earl. Let's turn now to Misty and Carmela to understand, where can health centers engage and how can they intersect on this work with philanthropy? Misty, why don't we start with you?
Yeah, absolutely. Thank you so much, Dr. Jacobs. I think this is a great question. So, as it's already been mentioned, structural racism definitely seems to be the baseline for many underserved communities, especially when it comes to gaining access to quality health care. So, in Indiana alone, we saw this past year a physician by the name of Dr. Susan Moore, who was a Black woman, died from COVID-19 after releasing a public video about the neglect that she received in care by a local hospital in Indiana. So unfortunately, the healthcare system that she was a part of, where she worked, failed her, and she related that to structural racism. And then when we look at education, where in some states, immigrants are required to pay the in-state tuition rate with no help of financial aid, and then not to mention the high unemployment rate that we're seeing amongst Brown and Black communities across the nation. Community health centers have been in a position to definitely serve those who are impacted by structural racism. So where health centers and philanthropy can intersect is by continuing to do the great work that we're already doing. And of course, with the expansion of those services. So in the philanthropic sector, we have the advantage of working closely with state legislation, as well as city and municipal agencies as an advocate for the community health center. I would say, while also identifying a much broader funding opportunity beyond the federal funding that the FQHCs are currently receiving. Jason mentioned earlier in the webinar that we created an executive director work group, and that work group was formed earlier in 2020, and we are looking at how the philanthropic sector supports the community health center. So this group started out as 3 federally qualified health centers being represented and has evolved to nearly 9 now. So we're growing at a rapid rate. So what we've learned within that group is that we all have very different operational structures. Some of us oversee very comprehensive volunteer programs, while others are responsible for managing federal and state grants, and some are even managing the community engagement, while others are focusing solely on funding from the general public, government agencies, and also private foundations. But no matter what our role is in supporting the FQHC, it's absolutely undeniable that the work of the foundations alleviates a huge administrative burden off of the community health centers. So nationally, our community health centers, where all of us can probably attest to this, that we're seeing that our staff are overwhelmed and we're short-staffed within the federally qualified health centers. So having the opportunity to support the organizations as a foundation, we take off a huge administrative burden to the federally qualified health center. So I also think, in addition to that, it's important for us to pay specific attention to state-by-state data. I know that was mentioned earlier, that the data that community health centers keep is prominent. And so if we're paying attention to the state-by-state data that's evolved since COVID-19, for example, in Indiana, the State Department of Health and the Indiana Black Legislative Caucus put together a statewide health disparities task force to introduce a plan for addressing disparities amongst our vulnerable populations in response to the impacts of COVID-19. One thing that the plan revealed was that underlying conditions contribute to increased risk of infection and illness, right? So now we have an opportunity to expand our programs that help address these conditions and can use our grant-making dollars to create long-term sustainabilities for these types of programs.
Hi there, Carmela. With the Castellano Family Foundation, you know, institutional racism, as been saying, plagues all of our systems, including healthcare. And one really important role for the health centers is to lead by example. One thing we're doing in California is the California Primary Care Association has been spending the last probably 8 months or so focusing on becoming an anti-racist organization and doing the hard work to do so. We have a commitment from our board chair, David Millett, that the CPCA board will take on this work as well, which I think is very critical and important for setting that example. Now, in terms of philanthropy and partnership, I think I have a story from San Jose that really shows the role and partnership for philanthropy and the health centers. And this plays out in my hometown of San Jose, where the Castellano Family Foundation supports the nonprofit Latinx sector. In San Jose, on the one side of town, the east side of San Jose, is where the Latinx community is located, and these nonprofits that we have historically supported are. And in the east side of San Jose, throughout COVID, the tremendous disparities were really playing out. Certainly folks were dying at a disproportionate level on the east side of San Jose. The Latinx community, the digital divide was really impacting our community, and testing was not happening in the east side of San Jose, where the extensive Latinx nonprofit sector was. Well, there's a community health center in San Jose. There's several, but Gardner was one that really stepped up and was really ready to provide these vaccines, and ultimately did it in partnership with the Si Se Puede Collaborative, a group of 5 nonprofits that the Castellano Family Foundation does support. So they had access to the community. They had the community Hispanic Plaza, which was a great place to host testing and vaccines, but they didn't have the provider. So partnering together with Gardner was a tremendous way to leverage both the federal and state resources that were coming to Gardner to provide testing and vaccines. And then through philanthropy and supporting this Latinx nonprofit sector of these 5 organizations that had tremendous access to the target population and the location, which was the Hispanic Plaza in San Jose. This ended up being a tremendous asset to the community and has brought the testing and vaccines to a place where they would not have existed. But it was certainly philanthropy's investment in these nonprofits to support them to be able to pivot and to be able to do new work during the COVID environment that allowed for this. Because if they were bound to the restrictive grant requirements of their grants, they would not have been able to pivot. And so there's a very critical role that philanthropy has to step up and allow for some flexibility and nimbleness of our nonprofit sector when they are faced with these kind of situations. And I feel that some of that has actually happened. But there's another really critical piece. That's about the strong partnership and recognizing the role that the health centers of the nonprofit sector play and philanthropy supporting it. But there's a very important piece of philanthropy that the George Floyd situation has really helped take to another level, which is philanthropy's own deficiencies and challenges in addressing the diversity issue, both in terms of having diverse staff and leadership in philanthropy, which is entirely lacking in a very sad state of affairs, and in investment to communities of color. For example, the Latinx nonprofit sector only receives a little over 1% of all philanthropic dollars in this country. So we have tremendous disparities that philanthropy really needs to tackle and address if it's really going to be able to play a role in helping address societal inequities. And I really hope to see philanthropy step up in a much stronger way to do so.
Carmela, thank you so much. And I'm mindful that as we've been talking, the time has just flown by. I think this discussion could probably go on for hours. But in the interest of time, what we're going to do is talk about a few things, and I'm going to ask each of our respondents to give us in no more than 2 minutes your thoughts on 2 things. One, and this, Carmela, really picks up on a theme that you've just raised. Over the past few months, the federal government has recognized the resources that are needed by health centers by providing additional funding through the stimulus packages. And while much is needed in terms of really securing long-term stability, the question that I would raise is, what role, building on what you said earlier, can philanthropy play in supporting health centers and in really encouraging a robust funding outlook for them? And I'd also like you to take just a moment to comment about what you would support for each of you. You've got a checkbook and you've got an extraordinary capacity for giving. And so what would you be writing a check for health centers to do? So I'd like to start with Carmela, and in 2 minutes, we'll do Carmela, Misty, Earl, Thomas, and hear your thoughts on both of these issues before we close out for today. Thank you.
Philanthropy has been really smart in California. They have a long history in working with the PCA and our regional associations. They have pooled funds in order to leverage. So philanthropy came together and funding through the PCA to get the dollars out to the health centers. And that's something that I think has been really smart, is for philanthropy to get together and leverage their own resources to leverage health center resources. And I hope other states take on the California model and do that. So what should philanthropy fund in health centers? Well, I've got a top priority. I think a payment stabilization and really, payment reform, and looking at how the community health centers are paid into the future is one critical area. And workforce is probably the top issue that we need support from philanthropy. Thank you.
Carmela, thank you. Let's move on to Misty.
So for your first question, I would say that the stimulus funding is only projected to last a short amount of time. And we realize that it is extremely important to have a sustainable plan in place for that long-term sustainability. So we definitely want to make sure that the programs and services that HealthNet plans to expand with the stimulus funding will ultimately create a sustainable future. So for example, HealthNet will be using the funding received for expansion of dental, behavioral health, and homeless services. Each of these areas will generate ongoing revenue via fee for service. So essentially creating a more sustainable future while also providing increased access to care. Our plans as a foundation are to continuously pursue strategies and partnerships locally and nationally to improve health outcomes for all residents in Indiana. If I were to write a check today, it would be for helping to fund our first mobile health initiative, in which ultimately will create access to care for those living within rural populations. And then thousands of dollars through our foundation are going towards helping with our patient assistance fund, because a lot of our patient population can't afford their medical expenses.
Thank you, Misty. Earl.
Thank you. Everything Carmela and Misty said. And then our focus is on capital dollars, and we'll never compare, no philanthropy will, to the amount of dollars the government brings in, but our dollars can be more flexible. So that small but mighty piece to the capital dollars can bring in the personal touches and accessibility. And I don't just mean accessibility with ramps, elevators, in the traditional sense, but accessibility, making sure people want to come in. Cultural touches have been tremendously successful in health centers, in communities that are of different cultures, different areas, and making it feel like a part of that community makes people feel more invited to come in. And so philanthropy supporting maybe those touches that the government dollars wouldn't want to invest in. They should, of course. I think they're great, but that's definitely a role we want to come in for. And I don't write any checks, but the trustees of the Weinberg Foundation very much want to write checks for sustainable programs that need that capital boost to get started. And nothing defines that more for us than PACE, Program for All-Inclusive Care for the Elderly. It's been proven that it helps older adults, and it's only accessible to 55,000 older adults nationally now. And some healthcare centers have already partnered to create their own PACEs. If they need some capital dollars to get started, Weinberg wants to be a piece of that and then turn over the sustainability to the government funding. But every older adult should have access to the comprehensive services that PACE provides to allow them to age in community in their home. So I look forward to hearing from folks about that.
Is that me? Oh, am I? Well,
Yes.
I agree with everything. Yeah, thank you. I think what we can do is help from the federal funding level. I think it's controlling. It's hamstringing. It doesn't provide the flexibility. So I think what philanthropy can do is help take the perceived risk out of things that work. And we always give unrestricted dollars whenever we can, because the things you get funded for are not the things you think. What we hear are not necessarily the things of highest value. A lot of them are not clinical. They get into workforce or community engagement or just kind of making it more inviting. So I think in general, I think what we can do is help make the government expenditures much smarter by having proven cases and models of what they should feel good about funding more of. If you are waiting for best practices, I hate that, because best practices, if everyone followed best practices, we would never have a new one, right? So in a way, to have a best practice, it requires doing something different than has been done before, or you're never going to have a new best practices. You have 50 years of experience. The sniffer is good, the judgment is good, the controls are in place. And federal money is, those big wheels go far, but they turn slowly. So I think what we can do is help be responsive, as others have said, listen carefully and just provide reasonable flexibility to go. I think one thing that we are going to write a check tomorrow in Puerto Rico, but I think one of the things that we've seen is the kind of a confounding and compounding effect of emergencies on poor communities, which tend to be highly associated with communities of color. Wealth and income are, there's a high correlation, but, health centers are required to have electronic health records, but they're not required to have backup power. And in California, where they said they're going to cut the power off for the next 10 years and throughout the Gulf states, throughout Puerto Rico, which we've seen, we've ended up reluctantly at first saying, wow, this resilient power availability, solar, battery storage that can ride through, without that, it doesn't work. It all goes down, not only losing all the drugs and refrigeration and all that stuff, but the electronic health records themselves are a confounding thing. So we, surprisingly, have now locked on to power is a prerequisite for health services today in 2021. Health centers aren't required like hospitals. So we are trying to build a larger fund. We've already done a few megawatts of power in Puerto Rico, but we'll be trying to lean into power for health as an initiative, resilient power that's green, that shouldn't wait. The communities that are typically in the last worst line on the grid ought not to have that be a compounding effect. And it often is in emergencies. We've seen it too much. And so that's one of the things that we're focused on, which I think gets to a lot of the other issues as a foundational piece. And as Earl said, it's a kind of a capital infrastructure piece as well.
Wow. Hearing you all talk, I was just reflecting on some of the things that we've recently invested in. And of course, it's all of the above. It is the Innovation Center at NAC, which we are so excited about. It's workforce, it's IT. We are writing checks for Puerto Rico, but I did want to mention one other thing, which was our decision to invest in an academic and research partnership through the School of Public Health at GW, because part of what that does is it provides the evidence base that's really necessary to support policy that helps community health centers and safety net providers and the communities that we're so privileged to serve. So, I'm sorry that our time has come to an end. Before I turn this back to Meryl, I did want to do one more thing. And that was to extend an extra special thank you to Carmela, who joined us today in her very last few days as the president and CEO of the California Primary Care Association. Carmela, you've been a transformational leader, a great friend, and really a visionary for this movement. You've taken on a leadership role in your family foundation, and we know that your next chapter is just waiting to be written. We can't wait to see what that's like, and we're sending you off with our warmest wishes in true health center spirit. So I'm going to turn this back over to Meryl to close us out. Thank you so much.
Thank you all. Thanks to our panel of philanthropic leaders. As NAC celebrates our 50th anniversary, these monthly fireside chats really offer an opportunity to highlight the impact community health centers are making every day across the country. And I hope today's discussion helped highlight how important our partners are to that work as well. At NAC, we're honored to represent the voices of 30 million patients, nearly 14,000 nonprofit community health center sites, more than 253,000 staff, and 12,000 community and consumer board members. You can visit our website at www.nachc.org and click on the 50th anniversary screen on our homepage, and you can hear all of the past webinars in this series. And thank you for attending today. Please don't forget to join us next month on Tuesday, June 29th at 2 p.m. Eastern. Take care, everyone. Thanks.